This closing session is going to feature these three speakers, and let's say without further ado, because you've had a lot of people talking at you and you don't need me to add my tuppence halfpenny. Professor Eugene Kinyanda, you're going to reflect on the day's proceedings and you're going to summarise the conference's key discussion points and identify the priorities which we've been discussing and which are going to be discussed at the high-level roundtable tomorrow. So thank you.
Thank you very much. I would like to thank the organizers for having invited me and facilitated my attendance of this meeting. I'd like to say that there's been a change of program. I think we as a group, we sat down yesterday and we said, well, we think these people have good cognitive skill, functioning, and I think they probably remember everything that we've discussed previously. So given that I have only 5 minutes, I'm just going to share a little bit about my research experience doing mental health research in Africa. And to begin with this discussion, I want to make a reference to a publication that was made by Victoria Simpkin in the BMJ Global Health this year, where you observe that Africa is home to 15% of the global population, responsible for 25% of the global disease burden, yet Africa only contributes to world research output of only less than 2%. So how do we improve this research and development output from Africa, specifically looking at the area of mental health? I will draw quite a lot from my experience setting up a mental health program and running it for the last 12 years in Uganda as part of the MRSC UVRI LSHTM unit in Uganda. And I want to focus on 4 areas. That is the research environment, the career path of a mental health researcher, increasing research funding, and increased commitment from African governments. On the research environment, I remember when I completed my PhD in 2006 and came back to Uganda, the research environment was not conducive for research, and I immediately left the psychiatric hospital where I was working and joined the mental health, the MRSC unit by then in Uganda. And by research environment, I mean things like addressing isolation. Most researchers, when you come back from the West, you come back to Africa, you have no peers, you have no collaborators to talk to. There's no administrative support when you're writing a grant. There's nobody to help you with the budget. There's no statistical support to calculate even simple things like power calculation, sample size, no clinical trials support to help you run a trial, no laboratory support to store your samples. So this is what I mean by addressing the research environment. And I would like to commend the MRSC for having supported the MRSC unit in Uganda for the last 30 years. And I think we need to address that issue. We need to address the research environment in our universities and in our different research institutions in order to promote African research. The other area is we need to develop a career path, clear career paths for mental health researchers in Africa. And we need to start early. We need to target the young people, the secondary students, in order to interest them into a career in mental health research. The Uganda Virus Research Institute has an innovation where they have an open day, where they open the laboratories, they open the research facilities, and invite pupils and students to come into this facility and test out, look at the microscope, do some experiments, try out instruments. We've even included mental health instruments which they play with. And I think this is one way of interesting the next generation of research leaders. Then the other area is we need to have clear career pathways for mental health researchers. My experience, I was just experimenting and trying things here and there, but I think this should stop. I think we should have clear career paths for future mental health research leaders. I know, for example, the schemes like the MRS CDFI, the African Leadership Award, where they fund you for 5 years, give you very good funding. But what happens after that? You do this scheme and you're left hanging. So I'd like to commend the Wellcome Trust. For example, they have a clear career pathway development scheme where you're from a junior researcher support, intermediate research, senior research. But I've seen many of my colleagues try to apply for these grants, and then they drop out. When they failed after resubmission, they lose interest. I think there's a need for more support to help African researchers, given the different challenges that they face, to be able to make it and win a successful grant. And I think also many of the other funders, I think they need also to look at this career path and see how you can sustainably support these researchers. Then the other area is, I think there's a need for increased availability of research funding to go to priority research areas in mental health. I remember when I started out 12 years ago, I couldn't get funding to support mental health directly. I had to do work, for example, in HIV in order to get funding. But I'm glad that the situation is right now improving, and I can see a number of streams of funding coming up. And the other area was that, in many of the international funding required that you have a PI from the West. Remember one time I worked on an application for 4 months. We're about to submit, then I realized I needed a PI from the West. And I just said, no, I'm not submitting this agreement, because I felt like this was part of me, which was going to hand over to another person to lead. This was not acceptable. So I think the funding mechanisms, I think we need to increase the funding for African scientists. Then the other area I want to talk about is I think there's a need to also hold African countries accountable to commit more money to research and development. In 2007, African countries under the African Union committed to invest at least 2% of the GDP in research and development. Current investment is only at 0.4%. So there's a need to hold these governments. And I think the environment right now, I think, is conducive to supporting this. Many of our countries, like Uganda, for example, we're struggling to, you hear the president all the time talking about going into middle income status. And so I think there's a need to, I think we can take advantage of that momentum to promote the investment in research. Recently, the government of Uganda committed to provide $8 million to an institution, Makerere University, under the Government Research and Innovative Fund. I never thought I would see that happen in my lifetime, but so I think such initiatives are good, and I think international donors can help by, for example, matching some of these, setting up matching schemes, such as the Newton funding mechanism, which in South Africa, for example, since 2014 has seen a co-investment by both South Africa and the funders under the Newton scheme of about 30 million pounds to research in South Africa. Thank you.
Thank you very much indeed. Thank you. Thank you, Prof. So, Professor Stanley Okolo, you're Director General of the West Africa Health Organisation, and a couple of weeks ago, 5th to the 6th of November, you had a linked conference, and I wonder if you could just give us a summary of what you discussed there, please. And you can refer to there was one particular question that I saw you became very animated.
Was that?
I was
only turning around to see who was asking the
I
question.
see. Okay, but it was about harmful traditional practices.
Yes, culture
and culture, which
yes.
I know you've dealt with before. So maybe you could just incorporate that. Thank you.
I know I have 5 minutes, and I know all of you have in your packs the outcomes of that conference. Let me just set the scene for you. The West Africa Health Organization, 15 countries in West Africa, population of about 400 million, as we all know, lifetime risk in terms of mental health, 25%, 20%. But all we did was to bring people together from all our countries. I think only Sierra Leone, where's Joshua? Solely Sierra Leone and Cabo Verde could not make it, but there were 13 countries. Then Tunisia, WHO, yes, Florence, Cameroon, Burundi, and DRC. But you know what? It's almost like giving feedback. Before you give people feedback, or when you're giving people feedback, they already know part of what you're going to tell them. If they don't, they haven't got an insight. Most of the outcomes and outputs of this day today is similar to the things that the conference agreed on the 5th to the 6th of November. At the conference, we were really looking at 3 things: leadership and, they recommended, what came out of it was leadership and investment, prevention and access for care, and then, of course, how you strengthen information systems, evidence, and research. And, if I go through them, you all have them, but it's really how do you raise the level in terms of policy, in terms of having dedicated unit within the Ministry of Health, how do you involve the CSOs, how do you involve people who are living with mental health disorders, and then in terms of investment, finance, and training. One of the things that didn't come out of it that we do have to think of is catch them early. And when I say catch them early, it's not necessarily trying to generate more people who will be pure mental health practitioners, but ensure that mental health training is not only introduced, but embedded in all our undergraduate curricula. Because really that is the way you start spreading the community of practitioners, because we have countries, I'm not talking of states or units, countries that have no trained psychiatrists. We have countries that have no psychologists. We have countries where it's only one person catering for a population of about 18 million. So the 9 per million is actually an average, you know, but you have places where it's only 1 person. So really, that's some of the things that I'm trying to blend, both what came out of here and what we did when we were in Burkina Faso, in Bobo Dioulasso. There was also some discussions about how we blend language blocks. Now, we do have the particular, some people think it's a challenge, but to my mind, it is an advantage that whenever we can agree things on a regional basis, we've already got the Francophone and the Anglophone together. We have had tremendous experience in West Africa of working with this because we have 8 Francophone countries, 5 Anglophone countries, and 2 Lusophone countries, the Portuguese of Cabo Verde and Guinea-Bissau. But we are all moving towards one community of people as opposed to a community of states. So we know how to do these things and bring them together. And I think I have Professor Ouedraogo from Burkina Faso in the audience, who, he's here? Okay? Who, yes, thank you so much. Enchanté, eh? Bienvenue. Now, it is really important to think about this because the number of countries that are Francophone are so many, but a lot of the literature, a lot of the support, a lot of the advances tend to, well, not the advances, but the published advances tend to be in English. And we've got to think about how we integrate this. And when we're doing that, that's when we then start answering the question about culture. Because really, let me give you a very clear example. Some of our hospitals in the 1 minute, thank you, I'll end in 1 minute. Some of our hospitals in the cross-border areas serve 2 different countries. But do you know that even within those 2 different countries, take an example of northern Nigeria and Niger, their local language is the same, Hausa, but their national language in Nigeria is Anglophone and Niger is Francophone. And I have a hospital that serves communities from both areas. So how do we bring that together? To answer the question about do people feel culturally challenged when you come in to do research? No, they don't. It is really a question of how you define culture, and it's a question of being, utilizing the people. So the program is not your program. It is their program, but you are the expert. You're trying to help them answer the questions. And that's some of the things that came out today about empowering people living with mental health disorders. That accountability is really key for us. Thank you.
Thank you very much indeed, Professor Stanley. And our last closing speaker is Dr. Julian Eaton, a British psychiatrist who's currently leading a research project which is integrating mental health into primary healthcare in Nigeria. And you've done a lot of work promoting access to healthcare services and the realization of rights, which somebody mentioned from the audience, for people with mental illnesses and psychosocial disabilities, and looking at it from this rights-based approach is a very, very important one. Your closing remarks, please. Thank you.
Thank you very much, and thank you for supporting us today in this. It has been a great pleasure organising this event with the Royal African Society. I think we have had a great day here together, and I thank you all for coming and participating, both those of you who are here and those who participated so richly in the discussions we had. We heard today that it often takes a crisis to create opportunities, and that's true. And people who are generally ignored take those opportunities. And I think we're a lot of very ingenious people who've become very good at taking these opportunities. We also heard that within families, it sometimes takes a crisis to start talking about something important like mental health that's at the core of us, but we often don't talk about it. It shouldn't need to take a crisis to raise the profile of mental health. People have a right to mental health. People have a right to decent quality care near the place they live, and to have a life that has well-being at the centre of it. We've heard, Diane mentioned, that there are conventions, the Convention on the Rights of Persons with Disabilities, that put those rights down clearly on paper, and we've heard very powerfully the voices of people with lived experience and many people who advocate with them to start using these mechanisms to make a change in countries in Africa. The second thing we heard about was about investment. As well as the innovative ideas that came up, we heard about investment. But what struck me most today was about all the resources that are already in Africa. There are so many brilliant ideas. There are so many strong communities. There are so many grandmothers. There are so many families and services that come from a traditional background, not necessarily some of the more Western style services that we've been talking about here. Crick mentioned that for every problem, there are twice as many solutions. And I think that's what I've been left with at the end of today's meeting. So how do we start working towards converting some of the ideas we've discussed here, some of the exciting, hopeful opportunities that we've been discussing, the ideas that have come from Africa to solve Africa's problems in relation to mental health and move forward? So we've got some very concrete things that we're planning to do as an organizing group of this meeting. First of all, we're going to summarize what we've discussed, what you've discussed, what's come from the floor here, and share that with you, of course, but share it also on a number of international forums where we think it's important that this voice is heard, both the things that came out of the meeting in Burkina Faso and the things that have come out of the meeting today. Tomorrow morning, we have a high-level roundtable of leaders from Africa who work in mental health with people who are involved in investing in mental health around the world to think more concretely about putting some of these things into practice. The Royal African Society has close links with the African All-Party Parliamentary Group here in the UK, and we are going to plan a meeting in Parliament to talk with people interested within that parliamentary group about mental health. We know that there are many structures through which we can raise the profile of mental health. We've talked about universal health coverage, and it's great to have Camilla here talking about that today. We have to have parity. There's no reason why we shouldn't be as equal as any other part of mental health. Why should we be right at the back near the mortuary? We want to be a part of integrated healthcare in parity with others. There's been various practical approaches to sharing these ideas that we've heard today. There are some articles that are going to be written. The BBC was here today. There's going to be a DevEx article. We had the editor of the Lancet Psychiatry here today. There are many ways that we're going to share this, and I would really encourage you to join the Mental Health Innovation Network, which has an Africa hub, where there's a focus of the work around Africa. I hear many voices of people who are engaged in this in an exciting way, and I hope you've had an opportunity to network with people, because it's only by working together that we're going to take these ideas forward. Thank you.
Thank you very much indeed. Thank you. So, Dr. Julian. So it just falls to me really to close this conference and to thank you. And you talked about partnerships because, of course, we at the Royal African Society, when we thought about this, it must have been, I don't know, 3 or 4 years ago, that we wanted to do something like this. Of course, we couldn't do it without our delivery partners. The Centre for, so I'd like to thank you all, the Centre for Global Mental Health, the Mental Health Innovation Network at the London School of Hygiene and Tropical Medicine, who've really guided the agenda for the day and have really utilised their contacts on the continent. Also, the support of our host and principal funder, the Wellcome Trust, without whom we couldn't have held this conference today. And they committed very early on to this idea, and so we really thank them wholeheartedly. Also, the Bill and Melinda Gates Foundation, who we were very keen to make sure this wasn't just people based in the UK from the diaspora and obviously, you know, the British health practitioners, but also bringing people from the continent, and they provided the funding, and they brought over nearly 20 health speakers from us from the continent, so thank you to them. Thank you also to CBM International, who worked with the West Africa Health Organisation on the linked conference that you heard about in Burkina Faso earlier this month, and the SHM Foundation, who've designed all of the conference materials and comic relief. And thanks, of course, to our marketing partners, AMREF Health Africa UK, the African Foundation for Development, Afford, Global Health Cafe, Mentally Aware Nigeria Initiative, Mani, and TEDx Houston. And, of course, to all of you for coming, for your contributions from the floor, and, of course, also to our speakers. And I really wish to thank from the bottom of my heart the wonderful team at the Royal African Society, and also Dr. Tedros, my good friend, the head of the WHO, who sent us his greetings at the beginning of this conference. And I know that he's very committed to ensuring that mental health is very much at the forefront of universal health coverage. And indeed, you cannot really aspire to having universal health coverage unless you do put mental health centre stage. And that is what I hope we have done today. It's the start of a journey. We hope to carry this on. Raising awareness about this very important topic in Africa is extremely important. All of you in your various guises can carry this work forward, and we will continue with it, and we hope that this is just the start of the journey. If you're interested in finding out, incidentally, more about what we do at the Royal African Society, there is an area out there. But I just want to end with the words of our patron at the Royal African Society's Prince William. And I'm sure that you know that the Duke of Cambridge is very, very interested in mental health here in the UK, but also he's very committed to the continent of Africa. And just to emphasise what he said when he says mental health has long been a neglected area of public healthcare, surrounded by stigma and misunderstanding. And it's impressive to hear how African health workers have come up with innovative new ideas in the most stretched of circumstances. And we mustn't forget that, as he says, Africa has become a hub for imaginative and creative ways of dealing with mental health challenges, both in the community and in health facilities. And this conference has offered an excellent opportunity to share this knowledge so that people suffering from mental health problems across Africa and indeed across the world can benefit. We have a networking session now, which we will also be hearing from our guest poets, Keith Jarrett and Belinda Zawi. But just to echo what the Duke of Cambridge has said, we are not forgetting, we cannot forget, and we will not forget that those who have mental health issues in whatever manifestations, that we are there, I hope, supporting them, and to ensure that this is the day when we say the suffering we've really got to start doing something about it, because it is not right that it should be something that's been so occluded. And I hope that we can manage and continue to put the spotlight on this very, very important topic. It's been my pleasure to be with you. I shall look forward to seeing some of you over the drinks reception. Thank you all very much indeed. Give yourselves a round of applause.